Hi everybody, it's Dr. Hall. Welcome to Unit 2 or Chapter 2 in the textbook, which is evidence-based public health. I love this stuff. It's really fun for me, so I'm going to do my best to control and curb my enthusiasm. So evidence means that we want to have data and actual numbers on evidence to actually support what we're doing. We don't want to do something in public health just because Steve thought it was a good idea or Beverly thinks that this intervention would work. We want to actually have evidence to support what we're doing so that we can be most effective as possible. So I like the construct that the book uses, the PERIE approach, P-E-R-I-E. And so that is identifying the problem, then figuring out the etiology. Etiology means the cause. Then coming up with some recommendations that we can think will be helpful based on evidence that we have, figure out how to implement them, and then evaluate things and see if it's having the intended outcome. So this is a really busy slide because it's everything that we're going to talk about in this unit. This first part of the lecture, we're just going to focus on problem. But what I wanted to do with this is give you just a listing so you can refer back to it later as you review, but also to show you that this is not new. We've already talked about this, but just in a slightly different way. So remember when we talked about the 3 steps in public health, like assessment, what's going on? Well, that's problem and etiology, figuring out what is going on and what is causing it. And then policy, what would work to help fix it or improve it? That's recommendations and implementation. And then, of course, assurance, is it working? That's evaluation. So the PERIE approach is just another way of breaking down these different functions, these different steps that we're doing. Okay, so now we're going to get started with how do we characterize the problem? How do we use data to understand what is actually happening? So what is the problem? The main ways that we're going to describe a health problem or a disease, you'll see the book often uses the term disease. I wish they would use condition, but health problem, what is the problem? So what is the burden, right? How much of a problem actually is it? Right? So how much death and disability does it cause? Death we speak of as mortality. Disability we speak of as morbidity. So morbidity would be like long COVID, right? So, or people who are out sick with COVID-19 infection, right? It causes people to feel sick, to be kind of disabled, either for a temporary period of time or a prolonged period of time, but mortality is actual deaths. Mortality deaths are easier to measure than disability, but we'll try to look at both for a lot of things. Then we want to understand the course of disease. Like, how much of a problem is it? How much of these things is it causing, and how does that change or differ over time? And when we do this, we're going to look at a number of rates. So this, the rest of this section of the lecture is going to focus on these different rates that we're going to be looking at and how we calculate them and what they tell us about a particular health problem. So incidence is going to give us a measure of how likely something is to occur over a period of time. Like, what are we seeing? How many people get diagnosed with heart disease or have a heart attack over the course of a year. Prevalence is how likely it is to be present at one particular slice in time. So if I went out today and I tested every single person, how many people currently have Lyme disease, for example? Mortality, how much death is it causing? And we're going to do that as a rate as well. And then case fatality rate. So of those who have the condition, how many of those people die from it? So we're going to go through those one by one. So incidence, again, is what proportion of the population is diagnosed with a condition in a certain period of time. There's almost always going to be a time qualifier. Does this per day, per month, per week, per year? It's usually per year, but we'll see that sometimes changes. So we could say, for example, how many people got infected with COVID-19 in 2021? That was kind of a big year for COVID, so let's look at that one. Now, we want to calculate this as a rate of how many out of the total population. So it's really important to look at the rate, not just total numbers, so that we can then make comparisons. I'm going to give you an example. So this is a chart of cumulative confirmed cases of COVID-19 in the year 2021 for a number of different states. So what we're looking at, let me get my pen here, right? So as time marches on the x-axis, what we're seeing is that the number of people who have ever been diagnosed with COVID goes up, right? As more and more people get infected, they just get added to the list of ever infected. That's what cumulative means, right? These people aren't all infected on the same day. It's just these are all the people who got infected over the course of the year as that year progressed. So you can see we started off not as 0 because some people had already been diagnosed in 2020. And then the different states, you can see it kind of goes up as time goes on. And if you take a look at this graph, you'd be like, wow, California, man, what is up with them? They were doing a terrible job controlling the pandemic. They had far more cases than anybody else. And then Florida and New York. So what is going on in those states? And look at us, Wisconsin, like we had such low case numbers. Well, the reason we had so much less COVID is that we have so fewer people. So our populations for Michigan, Wisconsin, and Minnesota are a lot smaller than the populations of California, Florida, and New York, which are some of the most populated states in the country. So if we look at it as a rate, if we make it, we would make it a percentage out of the population, but then those numbers get too low. So we're going to actually use a different number. Let me show you. So this is incidence rates. So what we're looking at now is cumulative cases per 100,000. So you can see that at the end of, here's Wisconsin here. So at the end of 2021, Wisconsin had over 18,000 cases per 100,000. So out of every 100,000 people, 18,000 got diagnosed. So that was actually like 18 out of 100. So that's 18%. But a lot of the health conditions we're going to be looking at, the incidence numbers are going to be much, much lower than that. So that's why we use per 100,000 people instead of an overall percentage. Now that since we've controlled for the total populations, you can actually make comparisons between the states. And you can actually see that proportionally, Wisconsin got hit just as hard by COVID-19 as Florida and Minnesota, and actually harder than California. So we had nothing to be proud of. We weren't doing particularly well. We're just a smaller state. So when you control for the population, right, when you look at things proportionally, you can then make comparisons. So we're always going to look at rates, and it's usually going to be per 100,000. All right, let's look at something that is not as prevalent, not with such a high incidence. So let's say, for example, what was the incidence of chlamydia infection in Dunn County in 2022? And you can find this data on the web. Our state health department maintains this information for us, and there's the link there if you want to go explore. You'll do that as part of your activity this week. But you can find out that the total number of cases of chlamydia diagnosed in Dunn County in 2022, 135. So there were 135 cases where somebody got a chlamydia test and it was positive. The total population of Dunn County is about 45,000. I rounded to make the math easy. So what we do is we say, okay, so 135 people were diagnosed out of 45,000. So what is that equivalent to out of 100,000? So 135 over 45,000 equals X over 100,000. And then we're going to solve for X by cross multiplying and dividing. And we're going to find out that X is 300. So the incidence rate of chlamydia in 2022 was about 300 per 100,000 people in 1 year. Another way to think about that is that's about 1 in 333 people. But you know what's interesting is we talked about in the last lecture the importance of life stages and how different health conditions are more or less common in different age groups, right? So certainly toddlers should not be having chlamydia, and we would suspect that young adults actually might have more chlamydia than other age groups. So let's take a look at it. So let's look at the incidence of chlamydia infection in young adults. So I'm going to pick people aged 20 to 24 to make it very relevant to most of you in Dunn County in 2022. So you can also find that information from the same website. And you can find that there were about 4,000 people aged 20 to 24 in Dunn County in 2022, and 60 of them were diagnosed with chlamydia. So we had 60 cases out of 4,000 people. So 60 out of 4,000 is equivalent to X out of 100,000. And we find that the incidence then was 1,500 out of 100,000. Which is way higher than what we had for the overall population, right? So much higher. And so it's 1,500 per 100,000, which is 1 in 67 young adults, right? So before it was 1 in like 333 overall people, but out of young adults, it's 1 in 67, right? This condition is much more common in young people. And when we use rates like this, we can compare different groups, which is so cool. Now, there are a few drawbacks to incidence. So in order for you to show up as a case in Dunn County of chlamydia or COVID, right, you need to actually get tested, and then for that test result to be reported to somebody. In this case, usually it's the public health department in the county. So you need to have good tests that are available. And I will tell you, in the very early days of COVID, we didn't have tests, right? So that was one of the first things we had to do, was develop tests. Then you also need people to actually get tested, and then those test results need to be reported and somehow collected so that we can actually have data on that. So incidence numbers are really, really awesome to have, but they have some limitations. So if we use COVID-19 as an example, so in the early days, once the tests were available, and there was a delay there, but people were using them to see if they had COVID, because then they would isolate or they would quarantine. And if you were at Stout back then, you were required to get tested. Was it twice a week or once a week? I can't even remember now. Isn't that crazy? But every single person on campus had to get tested regularly. So if you had COVID, we knew it and it got reported. So we had really good data in the early days of COVID-19. But nowadays, most people aren't testing. I mean, let's face it. So, even if they have symptoms, even if they have cold symptoms, a lot of people are just like, yeah, maybe it's COVID, maybe it's something else. I don't know. I don't feel that sick. I'm fine. And even if they do test, they're not reporting that to the health department the way they were. So let's take a look at the incidence numbers that we have for COVID-19 and see the impact of that change in testing and reporting behavior. All right, so this is another one of my favorite websites called Our World in Data. I could spend so much time looking at things. Okay, so what are we looking at here? So this is daily new confirmed COVID-19 cases per million people. So instead of number of cases per year, this is number of cases diagnosed per day. And it starts, you can look at the x-axis, it starts in early 2020, and then it goes all the way through 2024. And then it's looking at different countries. So I picked United States, United Kingdom, and Canada. And you can see that we all had somewhat similar kind of waves and peaks and outbreaks of COVID-19. And then all of a sudden, look, oh, things really changed, right? Looks like there's no more COVID. Like, COVID is gone. It's not happening anymore. Well, that's actually not true, right? It's just that people aren't testing and aren't reporting. So of the confirmed reported cases, it's totally dropped off. And you'd be like, Dr. Hall, how do you know that there's still COVID around? Well, let me show you. This is hospital admissions for COVID per million people. So again, these are less common things, so we're using per million instead of per 100,000. But anyway, what you can see is, so I moved it to, this is all the way from 2020, right? So we had lots of hospitalizations in those first 2 winters, right? Lots of hospitalizations. And then this is the winter going into 2022, 2023. And then here is the winter of 2023, 2024. So we can see that COVID is still happening, right? People are still ending up in the hospital from it. at lower numbers than previous, which is excellent, which could be for a variety of reasons. Either there is less COVID around and or people aren't getting as sick from it as they used to, right? So it's not as devastating, it's not as severe a disease as it used to be. The other thing that you can see from this chart that I love this, right, is that so United Kingdom drops off here. They stopped reporting it. They stopped collecting that data. They stopped reporting it out. Oh, this one has Ireland instead of Canada. So here's Ireland here. They stopped reporting it, right? So the United States still has some data on this, but it's no longer required. So there are just some groups and associations of hospitals that have decided to continue to report and collect this data. And then we extrapolate from them to get an idea of how much COVID hospitalizations how many COVID hospitalizations are happening in our country. So it's no longer a nationwide requirement. So our data is less robust than it used to be, but there you have it. Okay, so again, I changed the timeline, so I just got 2022, but I wanted to show we've got cases up here and hospitalizations down here, and you can see how the cases have totally dropped off, but the hospitalizations are still trucking along. So again, showing that disconnect, we're no longer capturing all of the cases. So another way that I know that we're no longer capturing all the cases is they survey wastewater, okay? So the interesting thing about COVID is that if you're infected with it, you poop it out, which is kind of weird. And then they can actually measure the sewage to see how many viral particles are in the wastewater. And that's exactly what they've been doing for a couple of years now. And you can see, so this one starts in 2022. There is less COVID around. There is definitely less COVID around. That's a great thing, right? But it's not gone, right? The levels are not as low as you might think based on the numbers of reported confirmed cases. Okay, so again, there's just as much COVID around, according to this, in 2024 as there was in 2023 for sure, and the winter of 2022, right? It's just not being measured and reported. So incidence has some limits, right? It has some drawbacks, it has some limitations. So let's talk about another one of the rates we're going to calculate, and that's prevalence. So prevalence is at any given moment in time, what proportion of the population actually has the condition. So instead of this time of like seeing who happens to get diagnosed, who happens to get tested, and that test result gets reported, what we're going to do is we're going to go out and we're actively going to look for this condition. And so we have a variety of different mechanisms for doing that in different ways for different conditions in our country. But one of the things that I really appreciated was Cornell University, this was in December of 2021, they were testing every student every week, and they were publishing all that data on a dashboard. So we were doing that too at Stout, but we weren't publishing the data on a dashboard specific to our campus. But what was great about this is they were testing everybody, whether or not they had symptoms, to see if they were positive for COVID. And so let's take a look at that data. Okay, so these are the different days that they were testing. So the first day was December 10th, then 11th, 12th, and so on, all the way through December 16th. And the different colors are whether they were student, faculty, or staff. You can see most of the people tested are students. Students outnumber everybody else by quite a large margin. And what you can see is those bars are showing us the number of positive tests, right? So on December 11th, they had a total of 227 positive tests out of, I think it's like 1,800 tests or so. I don't have my old lady glasses with me right now, so I can't read that number. But if you take all of the tests that were performed that week and calculate what percentage of them were positive, so out of 28,000 tests, 1,600 tested positive. So that was a 5.6% prevalence. So during that week, 1 in 18 Cornell students was infected with COVID, right? So That's prevalence. So prevalence really tells you how many people actually have the infection now, which is really useful information if you want to understand what your risk is of being exposed to it. Or if you're somebody who's working in healthcare or public health, you want to know, okay, well, how many people do we need to be prepared for who are going to be dealing with this problem during this time? So you might be curious then about how many people on any given day are actually infected with chlamydia. And the cool thing is that they do these surveys where they go out and they test tons of Americans on a regular basis who have no symptoms. They basically knock on the door and say, hello, I'm from the federal government. Can I test you for chlamydia? As well as some other things. So we actually proactively go out and test people. And here's some data on chlamydia. So there was a time period from 1999 to 2002, that's in the lighter blue, which is on the left, and then from 2013 to 2016, that's the darker blue on the right, and separated out by age groups. Now their age groups are slightly different than the ones that Dunn County gave us. So again, we're seeing inconsistent data batching, right? So people using different age ranges because we do not have a unified national standard, which is annoying. But so what we can see is that people aged 20 to 29 in 2013 to 2016, when they went out and just randomly tested people, 4% of them had chlamydia, right? So that's like 1 in 25 had chlamydia. So I don't know, next time you sit in a classroom of 25 people, right? Statistically, probably one of them is infected with chlamydia. Now, what's interesting is that the incidence was only 1 in 61 in Down County, right? So only 1 in 61 people actually got diagnosed with chlamydia. But we know when we go out and look for it that actually 1 in 25 people have it, right? So, oh gosh, that means that there's a lot of people who have it who aren't getting tested and don't know that they have it. Aha. Yes, that is why we still see lots of chlamydia. Okay. So we have lots of long-term cases and asymptomatic and undiagnosed cases. Chlamydia often doesn't cause symptoms, so you don't know that anything is up, so you don't go and get tested, and therefore you can give it to lots of other people. It's a very successful strategy for a germ. Okay, so that is prevalence, going out and seeing exactly how many people are infected or affected by a certain health condition at this in this certain period of time. Next up, mortality rates. So this is how many people in the population actually are dying from the condition. This is going to be a rate we're going to control for the population, right? So we're going to say per how many people. So again, if we look at COVID-19 deaths, we can see, right, lots of changes. These were daily deaths, but it was per million people. So again, we're looking at the United States, Canada, and United Kingdom in this particular graph. And it's really nice to see that we're seeing so many fewer deaths than we were. And there's lots of reasons for that. We'll talk about that in a little bit, and we'll get into it a lot later in the course as well. But one of the things I want you to notice is look how high the deaths were in the United Kingdom, right, compared to the United States, especially in those early waves compared to the United States and Canada. And there are lots of reasons for that. One is that the UK has a better reporting system than we do, especially in those early days when it was hard to necessarily diagnose somebody with COVID-19. They also got hit earlier than we did, and so we had a little bit more opportunity to mobilize and get ready than the UK did. But then you notice still the next winter in 2021, they also had a disproportionately higher mortality rate. And what's interesting about that is a big difference between our two countries at that time was that we rolled out our vaccine faster. So we rolled out our vaccine much faster to a broader range of people, whereas the UK only rolled out their vaccine initially to healthcare providers, of course, but then people aged 80 and up. And whereas we opened, I mean, we started with like 65 and up, and then it was 50 and up, and then it was everybody. But so we definitely saw some differences there. But then you notice in kind of going into the winter of 2022, the United States did a lot worse, while our vaccination rates overall were lower cumulatively. So anyway, there's lots of fun fodder for conversation and data mining and hypothesizing there. So let's look at some other mortality rates. So this is for something that's not an infectious disease. This is breast cancer. So it's kind of a busy chart, but I like it because it's got lots of interesting things. So I think I'm going to switch to my highlighter here. And this top line that we see here is breast cancer incidence, right? So how many people in Austria are getting diagnosed with breast cancer per year? And you can see that their rates are kind of that standard per 100,000. Now, this is specifically looking at breast cancer in female-bodied individuals. Most breast cancers, although not all, but about 99% of all breast cancers are in female-bodied people. So this is specifically looking at female breast cancer. And so you can see the incidence kind of went up and it's kind of leveled off, maybe gone down a little bit. This chart only goes till 2017. So there's your incidence, the number of people who are getting breast cancer per year controlled for the population. And then down here is mortality. So you can see how many people are actually dying from the disease. Now, this is out of the total population of female-bodied people. So out of all female-bodied people, you can see that about, so it's this axis over here, so about 25 per 100,000 are dying per year of breast cancer in Austria. Now, what that doesn't tell us specifically is, well, what about of the people who are actually diagnosed with breast cancer? Like, what's the likelihood that that breast cancer will be fatal for them? And you can kind of get at this a little bit. I'm going to change my color here to green. And so this line right here is 5-year survival. Now, what's cool about this is you can see that it's gotten better over time, which is really neat. Okay, so their mortality rate was 25 out of 100,000 women, all women, right? So it's a big cause of death in 2017. So 1 in 4,000. You might feel like 1 in 4,000, that's not a lot. That's a lot of the total deaths. Most people don't die in any given year, right? So yeah, so maybe 1% of the population dies per year. So that's 1 in 4,000. That's kind of a big chunk. So if we're interested in knowing how particularly dangerous a certain condition or disease is, then we're going to look at something called the case fatality rate. So that's what percentage of people who get the disease actually die from it. So this graphic that we're looking at is actually 5-year survival rate for US women with breast cancer. So this is also breast cancer. Now, when it comes to cancer, we often post survival rates, not fatality rates, and they're often with a certain time limit because so it happens to be summer of 2024 right now as I'm recording this. Shannon Doherty just died from breast cancer, right? But she'd had it, I think, more than 5 years. So she'd survived 5 years, but not 10 years, right? So we tend to do it as survival rates, but if I take that data and flip it, you can see the case fatality rate, right? So in 1975, 75% of people lived 5 years or longer, which means 25% of people were not still alive 5 years later. So in 1975, the case fatality rate for breast cancer was about 25% in the United States. And this particular graphic only goes to 2008. So you can see how it's fallen. So we've gotten much better at finding and treating breast cancer, and so the case fatality rate has gone down. But what's interesting is that the overall population mortality rate hasn't gone down very much, just because we're seeing increased incidence. So you can see how all of these things can flip-flop around. Okay. So let's look at case fatality rates for COVID-19, for example. So I pulled some data back during the pandemic when a lot of this was publicly available. And now, because we're not kind of in the throes of things anymore, they can't maintain those websites. So they had to divert their resources elsewhere. So the first year of the pandemic, up until kind of almost the end of December 27th, 2021, in Dunn County, there were 9,361 confirmed, diagnosed, and reported cases of COVID-19, and there were 58 deaths. So to figure out the case fatality rate then, right, you say 58 deaths out of 9,361 cases, that's a 0.6% case fatality rate. That means 0.6% of all the people who got infected, as best we can tell, died from COVID-19. Now that may seem like really, really low, like, oh my gosh, so 99.4% of people survived. So like, what's the big deal? Why was everybody freaking out? And why were we all having to wear masks and all that kind of stuff, right? Well, it turns out that 0.6% is still a lot if there's a gazillion people getting infected. So a small percentage of a huge number is still a very large number. So the graph that we're seeing right now is cumulative deaths due to COVID-19 in the United States from the beginning of the pandemic until mid-July 2024. And you can see it's basically 1.2 million, right? So 1.2 million deaths because there were practically 300 million infections. So even though it's only 0.6%, that adds up to a lot when practically everyone is getting infected. Yeah? Okay. So it matters, right? It's not just the case fatality rate, but it's the overall mortality rate, the incidence, all of those things matter in understanding the burden of a particular disease. And just to remember, right, from my other favorite website, looking at, so COVID-19, this happens to be global for all ages in 2021. It was the number 3 cause of death in the world, right? So even though the case fatality rate was low, because so many people got infected, it still had a huge impact on the world. And that's just in terms of deaths, right? It also caused a lot of disability. People were sick for a while. Some people are still sick from their COVID infection. So things to keep in mind. The other really interesting thing about case fatality rates is that they can change over time. So in the case of an infectious disease, so a germ like COVID-19, my computer's doing something weird. Okay, various things can lead to a decrease in the case fatality rate. So the case fatality rate can get better or lower if people develop immunity. And you can develop immunity against an infection either through vaccination, which is the safer way to do it, or by having actually been infected, right? So both ways will make you immune. Getting infected only makes you immune if you actually then survive the infection, which most people do, right? But obviously not everybody, right? 1.2 million people didn't. Now, some of those people had been previously vaccinated, yes, I know, but most of them hadn't, interestingly. Okay, so the case fatality rate can go down as you develop immunity in the population, either through vaccination or previous infection or a combination of the two, which is actually a big reason why people aren't dying from COVID-19 anymore, which is awesome and good and what we expected to happen. Also, you can have improved treatment. So as we're seeing with breast cancer, the case fatality rate has gotten better because we keep coming up with new and improved treatments, right? So 1975, 25% fatality rate. Now it is still about 9 to 10%. That's less than half, right? It's still a real serious disease. It still causes a lot of death. We still need to work on it, but we've made a lot of progress. The other way the case fatality rate can change or decrease is if the germ mutates and becomes less severe. Now, in terms of COVID-19, that's perhaps been part of what we're seeing, but it's really hard because we can't really tell because we can't isolate that from the fact that everybody now has some sort of immunity, or most everybody does. So case fatality rates can change. Let's take a look at that using Dunn County data again. So from December 2021 to December 2022 in Dunn County, we had almost 6,000 reported cases and 20 deaths. And that's a 0.3% mortality rate. So the year before, it was a 0.6 mortality rate. So it halved, right? And of course, 2022 is the year when most everybody who wanted to be vaccinated was vaccinated, right? So we saw a huge decline. So if we look at case fatality rate for COVID-19 for the United States versus the United Kingdom, again, so doing that comparison, you can see how it decreases in general over time. Now, you can also see that in 2021 into 2022, the United States had a terrible case fatality rate compared to the United Kingdom. Why? Well, fewer people were vaccinated, also, we don't have as good of a healthcare system. So in terms of people having access to care, right? So we're talking about quality of your healthcare system. There's lots of different components to that. We have more of a problem with access to care. Now you notice also that then it starts drifting up again. Now this is the case fatality rate. And I think what happens here is not necessarily that COVID is getting more severe, but that we're not capturing all the cases, right? That's when people started to not get tested, not report. So our denominator was getting smaller. So that changes. Okay. So this is also then looking at vaccine doses that had been administered and then looking at deaths from COVID-19, right? And we can see the impact of developing immunity on the mortality caused by disease, whether that's through vaccination or previous infection. So case fatality rates and mortality rates can change over time. So this whole initial section, I've been talking forever, sorry, was all about describing the problem. So we're talking about the burden and the course of the disease using incidence, how many people got diagnosed in a certain period of time, adjusted for the population, prevalence, how many people actually have the thing at a certain point in time, mortality rates, how many people in the population are dying from it, and then case fatality rates of those people who have the condition, how many die from that condition. All right, so next will be E, which is etiology, figuring out what is actually causing the thing. See you then.